You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about ventricular septal defects. We'll talk about the types of ventricular septal defects, their imaging features, their physiology, and intervention and when to intervene. So let's start with the types. There are 4 anatomic locations for VSDs: inlet, outlet, membranous, and trabecular. Inlet VSDs, which comprise 4% of all VSDs, are at the inlet of the ventricle, just below the mitral valve or the tricuspid valve. Inlet VSD can occur in isolation, but it usually occurs as part of a complete or intermediate or transitional atrioventricular septal defect, especially with trisomy 21 Down syndrome. Inlet VSD can also occur in coarctation of the aorta. Outlet VSD, which makes up 6% of all VSDs, but 33% in Asia, occur at the outlet of the ventricle, just below the aortic valve and beside the pulmonic valve. Outlet VSD will often have aortic cusp prolapse leading to aortic regurgitation. Membranous VSDs, which make up 80% of all VSDs, by far the most common, occur in between the tricuspid and aortic valve. Membranous VSD can have aortic cusp prolapse leading to aortic regurgitation. Sometimes the tricuspid valve leaflet may become aneurysmal and close the defect. Trabecular VSD, which makes up 10% of all VSDs, are muscular VSDs. Because trabecular or muscular VSDs are not adjacent to the valves, it is safe to perform closure percutaneously using a device. Part of the confusion is that there are 4 naming systems: the CHS database, the Van Praag, Anderson, and Hagler systems. The inlet VSD is also called AV canal VSD or perimembranous inlet VSD. The outlet VSD is also called subarterial VSD, referring to the great arteries, juxtaarterial VSD, conal VSD, subpulmonary VSD, supracrystal VSD, doubly committed VSD, or infundibular VSD. The membranous VSD is also called perimembranous VSD, perimembranous outlet VSD, or conoventricular VSD. The trabecular VSD is also called muscular VSD. Which view should you use to visualize each VSD? Inlet VSD, also called atrioventricular canal VSD or perimembranous inlet VSD, is visualized in apical 4-chamber view, where they can be seen adjacent to the atrioventricular valve or valves. Outlet VSD, also known as subarterial, juxtaarterial, conal, subpulmonary, supracrystal, doubly committed, or infundibular VSD, is visualized using parasternal short axis view, or alternatively subcostal and apical windows with appropriate angulation into the RV outflow tract. Membranous VSD, also known as perimembranous outlet, or conoventricular VSD, is visualized in a parasternal short axis view. Trabecular VSD, or muscular VSD, is visualized in the apical 4-chamber and parasternal long axis views. If you see a color jet from a VSD in parasternal short axis, you can easily tell which kind of VSD by what it is adjacent to. If the color jet is adjacent to the tricuspid valve at the interface of the RA to the RV, then it is the perimembranous septum and is a membranous VSD, also known as perimembranous VSD or perimembranous outlet VSD or conoventricular VSD. That's the one that makes up 80% of all VSDs. Again, if the color jet is adjacent to the tricuspid valve at the interface of the right atrium to the right ventricle, then it is in the membranous septum, and you call it you can diagnose it the membranous VSD. If the color jet is adjacent to the pulmonary valve at the interface of the right ventricle to the pulmonary artery, then it is in the infundibular septum and it's an outlet VSD, also known as subarterial, juxtaarterial, conal, subpulmonary, supracrystal, doubly committed, or infundibular VSD. This is the one that makes up 6% of all VSDs. Remember, perimembranous VSD is the most common VSD by far, and it lies within the membranous tissue adjacent to the septal tricuspid valve leaflet. In patients with unrepaired VSD, there is an increased risk of IE, infective endocarditis, typically involving the tricuspid and pulmonic valves. Let's dive into the physiology. Left to right shunt at a ventricular level actually causes left heart dilation, not right heart dilation, because all the volume the VSD shunts into the right ventricle ends up going through the pulmonary circulation and worsening the volume overload in the left ventricle. The most common acquired abnormality resulting from outlet VSD, which is the one also known as subarterial, juxtaarterial, conal, subpulmonary, supracrystal, doubly committed, and infundibular VSD, is prolapse of the aortic cusp into the outlet VSD, resulting in aortic insufficiency. While this prolapse of the aortic cusp limits the size of the outlet VSD and can lessen the left to right shunt, the aortic valve gets progressively more distorted as the aortic regurgitation progresses. Surgical closure is indicated based on the severity of the AR and is not dependent on the size of the left to right shunt. A restrictive VSD is a small VSD with a QP to QS ratio of less than 1.4. It produces a pressure gradient between the LV and the RV, but does not cause a hemodynamic impairment. However, because of the turbulence of the high-pressure jet from the LV to the RV through this small hole, there's a high risk of endocarditis associated with small VSDs. A non-restrictive VSD is a large VSD, usually with a QP to QS ratio of more than 2.2. Because the VSD is large, there's considerable left to right shunt, causing elevated pulmonary artery systolic pressure. Eventually, there will be equalization of right and left ventricular pressures. The increased pulmonary flow will lead to left atrial and left ventricular volume overload, heart failure, and ultimately Eisenmenger syndrome when the pulmonary artery to the right ventricle pressure gradient exceeds the left ventricle to the right ventricle pressure gradient. You should suspect VSD if there is a high-frequency holosystolic murmur at the left lower sternal border that does not change the Valsalva. Small VSDs are usually asymptomatic. Large VSDs can have dyspnea and fatigue. The smaller the VSD, the louder the holosystolic murmur at the left lower sternal border, often accompanied by a palpable thrill. When the VSD is large and there is increased RV and PA pressure, the VSD murmur instead occurs in early systole instead of being holosystolic. When ventricular pressures are equal, as in Eisenmenger syndrome, there may be no murmur across the VSD. Instead, there may be only a mid-systolic murmur due to dilation of the pulmonary trunk or a holosystolic murmur related to tricuspid valve regurgitation, and the S2 is markedly accentuated and single. When VSD is present, you will be asked to calculate the RVSP when a CW Doppler is placed on the VSD to measure the peak velocity across the VSD in meters per second. Not just on echo boards, but on general cardiology boards, this can come up. The RVSP equals the LVSP minus 4V squared. So, in other words, the right ventricular systolic pressure equals the left ventricular systolic pressure, which is just the systolic blood pressure as long as there's no LV outflow tract obstruction, minus 4 times the square of the velocity across the VSD. So, if the systolic blood pressure is 130, we can assume that the LV systolic pressure is also 130 as long as there's no LV outflow tract obstruction. And if the velocity across the VSD is 5 meters per second, then RVSP is 130 minus 4 times 5 squared. So 4 times 25. That gives us 130 minus 100, which is 30 milliliters of mercury. So that's our answer. RV systolic pressure here is 30 millimeters of mercury. If RV systolic pressure is higher, then the velocity across the VSD should be lower. If velocity across the VSD is higher, then the RVSP must be low. Beware that if the VSD is very small, then your CW Doppler across the VSD will be spiky, a tall and thin peak, instead of having a gentle downsloping plateau. Spiked CW Doppler will lead to an overestimate in velocity across the VSD, meaning it will overestimate the LV-RV gradient. So if you see a spiked CW Doppler across the VSD, you should use the mean gradient instead of the max velocity. The VSD murmur is holosystolic because LV systolic pressure and systemic resistance exceed right ventricular systolic pressure and pulmonary resistance throughout systole. Isometric hand grip increases systemic vascular resistance and will further intensify the holosystolic murmur of VSD by pushing more volume through the VSD. When to intervene? Small trabecular or muscular VSDs have a very high likelihood of spontaneous closure, typically 80 to 90%. The majority will close within the first few days of life. Spontaneous closure can also occur in childhood and even adulthood. Most isolated muscular and perimembranous VSDs are small and close spontaneously. The spectrum of isolated residual VSDs encountered in an adult patient includes the following. Small restrictive defects, the pulmonary vascular resistance is not significantly elevated and the left to right shunt is small, QPQS being less than 1.5 to 1. Large non-restrictive defects in cyanotic patients who have developed Eisenmenger syndrome with pulmonary vascular resistance at systemic levels and shunt reversal to right to left. Patients with moderately restrictive defects, meaning QPQS in between 1.5 and 2, who have not undergone closure for some reason. These patients often have mild to moderate pulmonary arterial hypertension. Patients who have had their defects closed in childhood who now present with VSD patch leaks. These are the 4 main kinds of patients you will see in adult VSD. You should close the VSD if there is a hemodynamically significant left to right shunt, meaning QPQS more than 1.5 to 1, with left heart enlargement and symptoms, as long as the PVR is less than 1/3 systemic and PASP is less than 50% systemic. This is identical to the criteria for ASD closure, except for VSDs and PDAs, it is left heart enlargement, whereas in ASDs, it was right heart enlargement. Adults with VSD and evidence of left ventricular volume overload and hemodynamically significant shunts, QPQS of at least 1.5 to 1, should undergo VSD closure if the PA systolic pressure is less than 50% systemic and pulmonary vascular resistance is less than 1/3 systemic. That's the wording from the guidelines, and that comes with a class 1 indication. So, for VSD patients, it is a class 1 indication to close if there are symptoms, but there is no indication for closure if there are no symptoms. Whereas in ASD patients, in our earlier episode, they still give a class 2A indication for closure if there's no symptoms in ASD. But for VSD, if there's no symptoms, there's no indication for closure. In addition, there are 2 additional indications for intervening in VSD. First, if there's progressive aortic regurgitation in the membranous or outlet VSDs, remember these are the 2 where the tricuspid leaflet or aortic leaflet respectively can fall in and partially close the VSD but worsen the AR, then there is a class 2A indication for closure. Surgical closure of perimembranous or supracrystal VSD is reasonable in adults when there is worsening aortic regurgitation caused by VSD. That's a class 2A recommendation. If there's a history of infective endocarditis, that's the other situation. They give you a class 2B indication for closure. Specifically, they say surgical closure of a VSD may be reasonable in adults with a history of infective endocarditis caused by ventricular septal defect, if not otherwise contraindicated, class 2B. If PASP exceeds 50% of systemic pressure and pulmonary vascular resistance exceeds 1/3 of systemic resistance, the guidelines still allow the VSD to be closed, but just more reluctantly so, as a class 2B recommendation, and that's the same policy as for ASDs, AVSDs, and PDA. Their exact wording is, closure of a VSD may be considered in the presence of a net left to right shunt, QPQS of at least 1.5 to 1, when PA systolic pressure is 50% or more than systemic and or pulmonary vascular resistance is greater than 1/3 systemic. That's a class 2B recommendation. But they put a hard stop in not allowing VSD closure if the PASP exceeds 2/3 of systemic pressure or pulmonary vascular resistance exceeds 2/3 of systemic resistance. That is the same policy as for ASDs, AVSDs, and PDAs. Their exact wording is, VSD closure should not be performed in adults with severe PAH with PA systolic pressure greater than 2/3 systemic, pulmonary vascular resistance greater than 2/3 systemic, and or a net right to left shunt. That is class 3 harm. After surgical repair of VSD, there's going to be right bundle branch block on ECG. So we've gone over the types, physiology, imaging, and intervention for ventricular septal defect.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.